Can we raise this a bit?
Existing in the middle of the lush and prosperous Sundanese area, which is rich of various culture and natural magnificence. Becoming milestone in educating the nation, building persons to be society servants and nation founders. Universitas Pajajaran, or UNPAD, was born due to the initiation of West Java leaders and government support to establish a higher education institution with various disciplines. Launched by President Sukarno on September 11, 1957, today, UNPAD has a large number of institutional achievements. Such as status improvement as the incorporated higher education with A accreditation. This achievement is in line with the commitment of all policymakers in order to accomplish the vision and mission of UNPAD to be excellent university in conducting a world-class education that is able to support the nation's competitiveness through a quality learning process and innovative research. The representative learning facilities and strategic campus in the center of Bandung City, Bandung Regency, and higher education zone in Jatinangor, Sumedang make UNPAD as an excellent university in conducting education, research, and community services. Through its best programs enabling to fulfill the needs of society, nowadays UNPAD has 16 faculties and 1 postgraduate school, totally consisting of 152 study programs. Faculty of Law, Faculty of Economics and Business, Faculty of Medicine, Faculty of Mathematics and Natural Science, Faculty of Agriculture, Faculty of Dentistry, Faculty of Social and Political Sciences, Faculty of Arts, Faculty of Psychology, Faculty of Animal Husbandry, Faculty of Communication, Faculty of Nursing, Faculty of Fishery and Marine, Faculty of Agricultural Industry Engineering, Faculty of Pharmacy, Faculty of Geological Engineering, Postgraduate School. Realizing the importance of learning process, curriculum and learning method are continuously developed in order to adjust the dynamics of stakeholders' needs. Nowadays, UNPAD has used student-centered learning method. That is, learning method focuses on students as the base to actively involve in developing knowledge skills, attitude and behavior with competence-based curriculum. Supported with professional faculty members and staffs, UNPAD is capable of generating competitive and characterizing graduates. Until now, it has registered 10,000 of students from all over Indonesia and hundreds of international students studying in Universitas Padjadjaran. To optimize the education and learning processes, UNPAD is supported with various representative supporting facilities such as library, basic science service center, language center, e-learning, teaching hospital, and dental hospital. In addition, UNPAD is also equipped with student dormitory, health facility, sport facility, campus transportation, banking, hall, and entrepreneurship facility. Such various facilities are supported with the utilizing of information technology. Besides supporting the academics quality, Universitas Padjadjaran also fully supports the activity of student character building through some student unit. As a part of society, Universitas Padjadjaran absolutely realizes that its function is limited not only in teaching, but also social and cultural aspects. Some social activities, society empowering, and research implementation have been conducted to give real benefits for all society. Universitas Padjadjaran, straightening and developing together with society, from West Java for Indonesia to the world through SDGs.
Greetings from Transcendent 2021, massive open online course in cleft lip and palate held by Faculty of Dentistry, Universitas Padjadjaran, collaborating with Smile Train and YPPCBL that has been going for a few weeks. You may see the trailer now. Please play.
Are you interested in learning about cleft lip and palate with experts from around the world? And you can learn this for free while gaining 3 credits. Come join our online course in collaboration with Faculty of Dentistry Universitas Padjadjaran and Smile Train.
Hello, my name is Shiva Biandra, and I'm a student from Faculty of Dentistry, Universitas Padjadjaran. I see that we came from different countries, so I think it's appropriate to say good morning, good afternoon, and good evening to everyone here. Greetings to Dr. Syed Altaf Hussain, M.S., FRCS, DNB, Senior Consultant from Sri Ramachandra University Hospital, India. Thank you for being here. It's been a pleasure, and we really appreciate your presence here. How are you, Doctor?
Good morning, everybody, and greetings to those who are later in the day. And many thanks. Thank you very much for having me here. It was it's indeed a pleasure. And I just saw your video, and it's quite impressive what you have achieved. And I hope the university and all of you go from strength to strength. And I wish you the very best. And I particularly wish to thank Dr. Sarilita. She has been extremely clear in her communication. She has told us exactly what we want, and she has been coordinating with myself and my colleague, Dr. Vishnu, and it's indeed been a pleasure. I again wish to thank everybody involved in this, and I just want a little bit of feedback. Maybe we should do it at the end of the session, whether was the content appropriate, because there sometimes one tends to go too much into technicalities, because it's not only surgeons and medical students or dental students involved in this. And so I wish to know, because I have 2 more talks, so I wish to know how to tweak them. So thank you.
Thank you, Doctor, for the kind words. And we also have Dr. Erli Sarilita, M.Sc, Ph.D. from UNPAD as our moderator. Thank you so much, Doctor, for being here. So greetings to all of the participants. Thank you for participating in this course, and thank you for attending these live discussion sessions. So, Doctor, today is our 5th and last live discussion for this 3rd week. We have discussed about cleft palate in this week, and today we are going to discuss about palate repair. This live discussion will be separated into 2 sessions. The first session, the doctor will be answering the questions that have been filled out by the participants in the MOOC website. The question will be presented on the screen. They all have already watched the lectures about the related topics, and I think not everyone can make it to this live discussion, but I'm pretty sure all other 300 participants that have registered to our course will watch the lecture and also the live discussion that will be posted. In the second session, the participants will have the opportunity to ask the questions directly to Doctor through the comment section. The participants can write down the question, their name, and what institution they are coming from. So first session, I would like to give the spotlight to Dr. Erli Sarilita as our moderator and Dr. Syed Altaf Hussain as our speaker. Dr. Erli may start the first session and lead today's live discussion. Thank you so much, and we can move on into the first session.
Okay, thank you, Shifa, for the opening. Dr. Hussain, how are you? Very nice to meet you here today.
Very well, thank you. And thank you very much for having me here. And I thoroughly enjoyed interacting with you and looking at your introductory section. Let's get on.
Okay. Doctor, the committee has collected several questions from the participants. So our participants ranging from undergrad, dental students, medical, nursing, and then we also have residents in oral maxillofacial surgeon. We also have master and PhD students here who are interested in various aspects of cleft lip and palate. So you don't have to worry about your lecture is all great. Thank you very much, Doctor. We all really enjoy it. And committee perhaps can help me to display the question. Okay, we will have the first question here from the participant, from Faras. What are the important things that need to be considered to prevent secondary bleeding as a complication? Doctor?
Okay, that's a very, very interesting question. And since it's a mixed audience, let me just go a little bit into what secondary bleeding. I'm sure some of them may benefit from that. When you say primary bleeding, that happens when the operation is happening. And then you have a delayed bleeding, in primary bleeding, which is reactionary bleeding, it's called, which happens in the first few, 24 hours or 36 hours of operation. That's because of the clot dislodging. That when you say secondary bleeding, that particularly refers to bleeding that happens in a facial operation in a face or head and neck operation, it typically happens about 5 to 7 days after the surgery. The causes being put forward are because it's probably because of minimal infection. Sometimes there is overt infection, but many a time you just can't find any infection. Minimal infection, which has kind of made the tissue softer, and probably some of the vessels which have given way, and it's caused a bleed. So in a cleft, I mean, in a cleft lip or cleft palate, it typically happens on the, I mean, I have come across a few times on the 5th day, 5th or 6th. It's like clockwork. If it happens, it happens on the 5th or 6th day. Now the thing about secondary bleeding is, if you are sure it is secondary bleeding, uh, the best way to tackle it is non-operative. You do not want to go and explore this bleed. You don't want to take it back to the theater and try to catch it, because at that time, at this time of the first, just after, in the first week following the operation, the tissues are reactionary. The tissues are in a high flow phase. Everything is much softer, edematous. There, if you try to catch the bleed, you may not succeed. You may just end up tearing more tissues. So what I do this applies to cleft lip and cleft palate, yeah. So it may not apply to other situations. So you need to be very specific. I'm talking about the cleft palate now. So what I do is I bring if the patient is far away from you might have discharged the patient. Normally I discharge the patient in the first 24 hours after surgery. If I operate today, tomorrow the patient is home. So very likely the patient is away. So I ask them to put the head end up, so that the congestion in the venous congestion and even the arterial pressure in the head is a little bit lesser. Then I ask them to wet a handkerchief and keep firm pressure on the palate. Open the child's mouth, wet a handkerchief and put it in the palate, and then transport the child as fast as possible to our facility or any nearby facility. Sometimes our patients come from far away. So once the patient reaches the hospital, we take blood for a full, a complete blood CBC, complete blood count, and grouping and cross matching, because we don't know how bad the blood loss is. So, and then we start the process of getting blood ready. We may or may not use. Many a time, I've never had to use blood, but we keep the blood ready, and we. All you need to do is take a piece of saline soap gauze, wear a glove, take a piece of saline soap gauze and apply direct pressure on the palate. And at the same time, when you take the blood, keep an IV, put in a Venflon, and I give an antibiotic. Normally, Augmentin helps. Augmentin has both gram-positive, gram-negative, and some kind of anaerobic cover, because many of this very likely is from an anaerobic subliminal infection. So with this, it controls. Luckily, secondary bleed is in my hands not very common. In the last many years, in the last 15 years, maybe I would have had 5 or 6 times. And sometimes it has happened when the child is very far away from sometimes 1,000 kilometers from the hospital. So I've been able to manage it just on phone. Keep pressure. If you do not have access IV line, all you need to do is start oral Augmentin. Usually it's a child. So Augmentin syrup, probably it also, in addition to the systemic effect, probably it also gets absorbed from the palate itself. So oral Augmentin also works, and it is if it can be avoided, best is not to re-explore the patient. I've never had to re-explore the patient. Once we had operated in another country, and in spite of our instruction, the surgeon panicked a little bit and took the child to the theater and tried to stop the bleed. It became a bigger mess. He could stop the bleed, but they ended up with a fistula. So that is how I think you need to control. And then if you want to prevent it, now I'm sorry I went around the thing, but it's a very, very important question. So I thought it's best that I elaborate on it. To prevent it, normally, if you just cover it with an antibiotic, I mean, of course, when you're operating, you need to be meticulous. You very, very gentle handling of tissues. It not only helps in stopping preventing bleed, it also kind of makes your operation, the results much better. Very gentle handling of tissues, and cover the child with antibiotic. What I do is, previously we never used to give antibiotics when we started out. Then we found that we have some secondary bleeds. So what we do now is we give a preoperative antibiotic, and then I put the child on oral antibiotic for 5 days, because some of our patients come from far away. Usually 3 doses are good enough. One before you start the operation, another in the same evening, and the third the next morning. So 3 doses are good enough for cleft surgery. But then when the patient is from far away and we don't know the nutritional status, I give them antibiotic for 5 days. And we have now never had any secondary bleeding in the past many years. I think this covering with antibiotic, though looks like it's overkill, seems to prevent this. Does that hopefully answer the question?
Yes, thank you very much, Dr. Hussain. Is really clear. We learned a lot. So maybe next question, committee. Okay, from Maulida. What can we do to minimize the sequelae from doing cleft repair?
Okay. When you say sequelae, you're talking about growth disturbances, or I mean, is this question is from the person who asked this question is not here, isn't he? He or she is not here.
Let me check. Maulida, I think Maulida is here. Maulida.
Do you want to elaborate on this question? Is it you're talking about lip repair, palate repair, or what kind of sequel are you talking about? Immediate complication, long-term complication? I presume it's long-term complication. If I have some clarity, it'd be better. Otherwise, it may be a very long answer.
Yeah, maybe that's the long-term sequelae.
Long-term sequelae. Okay. Well, see okay. There are 2 aspects to this. One is it's the operation that causes. I mean, the obvious thing is I've seen some unoperated clefts. They don't seem to have any problem with the mid. I presume you're talking about mid-phase hyperplasia. Is that correct? When you say long-term sequelae, you're talking about growth disturbance. Is that the answer?
In the chat box, Maulida write in the lecture, for example, the midline sequelae. The midline sequelae. The midline. Okay. Yeah.
Yeah. Okay. Mid-phase growth disturbances. Brilliant. So there are 2 aspects to this. One is, like I said, it's the operation that causes it, because we are adding scars. However gently you operate, you still leave scars. The nature just forms scars. The other one is sometimes there might be an inherent growth disturbance. The child may inherently have a tendency to have a smaller or a retrusive midface. So there are two aspects to this. I'll concentrate on the damage caused by the surgery. From the looks of it, there is so much literature on it, and from personal, I mean, add that to personal experience, I find that one, it is the lip repair, if it is very tight, is more likely to cause mid-face hyperplasia. And when you do the palate repair, the where you place one, the timing of the operation, number two, where you place your incisions, and number three, the amount of damage you caused. So since I spoke about the palate, I'll just concentrate on the palate, having already said that lip repair also can contribute to it. Since my topic is the palate, and to keep the answer reasonably brief, I'll concentrate on the palate. So it's best to, there is a conflict between mid-face hyperplasia and speech. The earlier you do the repair, the better the speech results are. But the earlier you do the repair, the more problem with the mid-face. So you need to strike a balance. The window for speech is between 9 months and 18 months. I mean, the speech therapist would say that, speech pathologist would say that if you, ideally, the speech, the child starts babbling and kind of imitating speech from 6 months onward. But we are not talking about when it starts. We want we should kind of concentrate on when speech gets established, so that the speech doesn't shift from the normal to the abnormal. So I think nowadays I operate when the child is about 1 year old. So that is the timing. One is timing. Number two, the lesser the incisions you make, probably the better. Like when I was presenting, I mentioned that ideally there should be only one cut in the midline, and everything else can be done by mobilization from the midline incision. This particular technique was popularized. Practiced and popularized by Mr. Brian Somerlath. I think it's a very good technique, except that we'll come to that. So minimize the incisions, and if you have to make lateral release incisions, do what is minimum possible. If the anterior is reasonably close, so I only make 1 Langenbeck incisions, which are just lateral release incisions, and I place them in such a way that the incision stays within the mucoperiosteum and doesn't go into the gingiva. When you take an incision too laterally nearer the teeth, and you place it through the gingivoperiosteum, you tend to damage the ligaments that hold the teeth. Periodontal ligaments can get damaged, and the resulting fibrosis can actually damage the eruption of the teeth, and also cause severe fibrosis that will not allow the palate and the alveolar arch to grow normally. So 2 things I've told you now. One is time, about 1 year, and then the incisions you keep to a minimum, and if you have to make incisions, make them in such a way that you don't cut across the periodontal ligaments. There is another technique which is gaining a little bit of popularity. It was put forth. It has been there for some time, but it has been popularized again by Michael Carstens, who's a contemporary again. So it's called alveolar extended palatoplasty. You place if you have to make lateral incisions, you place them, you lift the entire mucoperiosteum and the gingivoperiosteum together. See, what we are talking about, when you make release incisions, the traditional release incisions, are on the mucoperiosteum. That is the periosteum of the palate itself, and they should not go into the gingiva. Now, the radical shift in this is you lift both the gingioperiosteum and the mucoperiosteum from the tooth buds. I mean, from the alveolus, so that you do not cut across these structures and cause more scarring. So you take it, I mean, lift it as one unit. I'm still not brave enough to do it in babies. I've done some, but I'm a little bit worried. And so far, the babies have done good, but I don't have very long-term follow-up about this alveolar extended palatoplasty. But when I have to revise, or when I have to go and do an older patient, then I always lift it. I do the alveolar extended palatoplasty where I lift it from the teeth, from the interdental spaces. The third thing is make your operation, I mean, be very, very delicate the way you handle your tissues. You need to be very careful, and if possible, put everything back into place. If you can, if you have to lift flaps, mucoperiosteal or extended gingioperiosteal, whatever flaps, try to suture them back in place and not leave large, wide raw areas. And then as the patient grows, you may have to monitor the child, and sometimes orthodontists are able to make appliances which should hold this in place. And one way of doing this is, in case there is a reverse overjet, try and sort out the reverse overjet, if I mean during the growing phase, so that you have a lock. You have a posterior overjet which acts a kind of lock. I do not know, but it's better than. And once it happens, then you have distraction and orthognathic surgery and stuff to tackle it.
Yes, thank you very much, doctor. Very clear. So indeed, to treat cleft palate, multidisciplinary treatment are in need, right, doctor?
Absolutely.
So not only surgery, but also we have to monitor the patient, and maybe the patient will need orthodontic or maybe orthognathic treatment. Okay, thank you, committee. Next question, please. From Hasna. What will happen if the blood vessels from greater palatine artery got damaged during the procedure of palatal repair, and how to overcome that problem?
Okay. The answer to that is simple. Don't do anything to the greater palate. Don't damage the greater palatine artery, because once you damage it, if the flap is not raised, like in a two flap technique, you are raising the entire flap on in the Bardach's long flap technique, you are raising the greater palatine on you're raising the entire flap on the greater palatine artery. In which case, what I've noticed is the anterior 1/3 of the flap necrosis. You'll need to later sort it out by expanding. I mean, everything collapses once the anterior 1/3 of the palate necrosis. The alveolar arches collapse. There's very, very severe hypoplasia of the midface, and the only way of tackling that is to expand it and then plug that hole with maybe a tongue flap, anteriorly based tongue flap. So one is that. So it's best to. Luckily, I've not personally done too much damage to the greater palatine artery. Maybe I might have divided one in many years ago. Best is when you start the operation, you identify the vessel at the earliest and isolate it. So what I do is, one trick that I do is, I go from the hard palate and I go in the plane between the bone and I lift it, the entire periosteum of the hard palate, and I dissect backwards till I see the vessel. And the vessel luckily is very quite large, very difficult to miss the vessel if you're looking for it. And then you lift the vessel off. I mean, you can pull the vessel out from its tunnel, its bony tunnel. And then what I do is, once I push the vessel completely back, I go behind the vessel and release all the gingival and periodontal ligaments. There are several gingival ligaments there, which once you release you are able to pull the vessel out from its canal, and the palate pretty much moves back and forth. And the way to prevent bleeding is just common sense. I mean, prevent damage to the vessel is, don't cauterize too close to it. Identify the vessel, take some time, don't be in a hurry to get on with things. There are two phases in surgery: places where you can operate rapid, fast, and there are times where you have to go really slow. When you are particularly in the beginning of your career, when you go near the greater palatine, treat it with the utmost respect. It's a fairly nice vessel to handle. It's big. It doesn't get damaged very easily, and you can go all around it with your dissector and pull it out of pull it out of its tunnel, so that you get laxity to move the tissues back and forth. Once it's damaged, I don't think you can do much except secondary reconstruction.
Thank you.
And maybe if it's a small rent, if you're a skilled microsurgeon, maybe you could take a suture on it. Luckily, I have not had to do. Maybe I did once. I nicked it once long ago, and I managed to suture it. So, did that answer your question?
Yes, really clear. So, doctor, you just give my students like clinical relevance. I teach anatomy for the first and second year for dental students, and sometimes they didn't understand that what they're actually learning in the first and second year, they will bring it all the way when they're maybe already a surgeon and practicing dentistry and medic, so they need to retain the information they get. That's right, Doctor. Thank you very much. We still have questions here. Committee?
Actually,
From
we
the
are going
chat
to
books?
move to the second session, Doc.
Oh, second session. Okay, so second session, it means that we will receive questions from the audience. We have here Dr. Andrew Lorat. He's actually the orthodontic resident from Universitas Pajajaran.
Hi.
He asked, which suturing technique do you prefer for cleft palate patient, and what kind of suture material do you prefer?
Well, okay. For the palate, we always use absorbable sutures. I use polyglactin vicryl. I use 5-0 vicryl on a reverse cutting needle. And it works well for me, so there is never a problem. If it is an older patient, or if I'm doing a secondary surgery, I use a 4-0 vicryl, reverse cutting again. And suturing technique, I just use simple sutures, except for the palate, where I would use a horizontal mattress suture.
Okay, thank you very much, Doctor. So we have arrived at the last question. That was the last question from our participants. Before we end this live discussion session, Doctor, I would like to ask your suggestion for our students. we have young generations here. Maybe they would like to be a surgeon one day. So maybe you have message for them how to be an excellent surgeon.
Yeah, you just have to be good. Yeah. So it's a being a surgeon is a commitment. Of course, it eats into a lot of your personal time, and it also there are many rewarding moments. There is no other specialty that transforms a person's appearance and probably touches their lives as much as a well performed operation, particularly when it's on the face. Like we're talking about a cleft or any craniofacial deformity. So it is a very challenging specialty. You need to be really committed to it. Sometimes it eats a lot into your personal time. I mean, if you have to be good at something, you have to sacrifice other things. So it is very rewarding, but you have to pay a price for it in terms of personal life at times, and sometimes the stress that goes with it, because what you do can, if you don't, if things can go wrong, and sometimes every time you anesthetize and operate on a patient, you are taking a personal risk on the life of the patient as well, to an extent. We take all precautions. We do. You need to be very meticulous, and you need to be knowledgeable. Like you said, anatomy. See, the key to a good surgeon is his or her knowledge of anatomy. You need to really know your anatomy, and you need to relearn many a time. And sometimes every time you do operation you don't do regularly, you may have to go back and read on your anatomy, read the technique repeatedly. And plastic surgical operations many a time happen more in the brain than, before you operate on the patient, you need to plan your operation very meticulously, because these operations are not standard many a time. So you need to plan. The operation happens in your head first before it happens on the patient. So, and then there is, like in any walk of life, the more meticulous you are, the better your results are. So does that answer the question?
Yes, thank you very much, Doctor. Really a good message for the students, maybe who will listen today and maybe after today. Perhaps that's all the live discussion session. I will return this to our Master of Ceremony, Shifa. Thank you, Doctor.
Thank you.
All right, so we have reached the end of today's live discussion. It was a great opportunity for all of us hearing the valuable knowledge from Dr. Syed Altaf Hussain on this special occasion. And thank you for Dr. Erli Sarilita for moderating this session. In these hard times of the pandemic, we can still find the bright sides. I believe this will be an inspiration for all of us to learn about cleft lip and palate more and more, even further, and to implement the best treatments for our cleft patients. Before we end today's session, thank you so much to everyone. Goodbye, stay healthy, everyone.
Thank you very much. Thanks very much, everybody, and have a great day and stay safe. Thank you.
Thank you, Doctor.
Very much. And Vishnu, do you wish to speak to Dr. Sarilita?
Oh yeah, Dr. Vishnu. Oh yeah, Dr. Vishnu?
Yeah, he's just coming online. If you can just come in here, Vishnu.
Oh yeah, I can see him. Let me put him in spotlight. Hi, Dr.
Hello, ma'am.
Vishnu.
Good morning. Yeah,
Good
hello.
morning.
One
Thank
minute.
you for helping us arranging this lecture.
Yeah. It's a pleasure, man. It's a pleasure. Thank you. It's nice to know you.
Yeah.
And hope we have more opportunity to work together.
Yeah.
Thank you.
Yes. Thank you, Dr. Vishnu. Thank you, Dr. Hussain. Maybe we can meet again someday very soon.
Oh, I'm
Hopefully.
sorry. Can we take a picture first with
Oh yeah.
the participants left in the room? Because
Okay. We'll take
it
pictures.
was the live discussion was so amusing that I forgot about this session. Oh, Dr. Vishnu, don't turn off your camera, so we can take pictures together.
Okay.
All right. So everyone, please turn on your camera. I will count. 1, 2, 3. Once again. 1, 2, 3. Another one. 1, 2, 3. Thank you.
Okay, thank you. I will send you all the screenshots and the recorded live discussion. Thank you.